Assalamualaikum warahmatullahi wabarakatuh. We are from Group 5. We'll be presenting about discovering a hidden PLSVC during minimally invasive surgery. This case presentation on diagnosis of persistent left superior vena cava by transesophageal echocardiography, which during minimally invasive cardiac surgery. So my teammates will be presenting by their parts and enjoy.
Hi, my name is Aisha Umaira and I will be presenting on the introduction of this case study. So, before we dive into the case details, allow me to give a brief introduction to set the stage. So, persistent left superior vena cava, or in this presentation, we will call it as PLSVC, is a rare vascular anomaly where an additional vein on the left superior vena cava remains after birth instead of disappearing during the fetal development. Although that this is rare, with a prevalence of about 0.3 to 0.5% in the general population, PLSVC is actually the most common thoracic venous anomaly. So, in most cases, it drains into the right atrium through the coronary sinus and it does not cause any symptoms, meaning that many individuals live their whole lives without ever knowing that they have this disease. But however, unexpected findings like this can become very important in medical settings, especially during procedures involving the heart. And in this particular case that we are presenting, a 63-year-old man underwent minimally invasive cardiac surgery, which is specifically for tricuspid valve repair and left atrial appendage ligation. So, while the surgical team had planned the procedure based on the preoperative imaging, the intraoperative use of TEE revealed an unexpected structure, which shows a persistent left superior vena cava running alongside of the patient's heart. So, this sudden discovery during surgery required the surgical and anesthesia teams to quickly adjust their strategy, especially for establishing cardiopulmonary bypass and venous drainage. But more importantly, this case highlights how critical intraoperative echocardiography is by not just for confirming preoperative findings, but it is also for detecting hidden anomalies that could dramatically affect the surgical management and also the patient outcomes. So, through this case, we learned how TEE serves as an essential tool in turning unexpected anatomical challenges into manageable situation, ultimately leading to a successful surgery. So, with that introduction, let's now move on to the analyzing the specific TEE findings that led to the diagnosis. That's it for me.
Good evening to Sir Muhaimin. My name is Nurchala Jasmine Nozehan and I'll be presenting the procedure of TOE or TEE depending on where you're from. So basically for the pre-procedure, we will have to apply IPSG-1 which is identifying the right patient for the right procedure. So we will have to identify the patient with at least two identifiers such as that date of birth or hospital ID, and then we will have to explain the procedure clearly and explain the and be transparent with what we are doing. This involve the sedation procedure and the after effect, and also to make sure that the patient signs the consent form. And then we will have to carefully review the contraindications of the patients, such as we have to monitor if the patient has any esophageal abnormal structures or any tumors, or even if the patient has underwent a recent surgery. And then, before the procedure being done, we have to ensure that the patient has at least fasted for 6 hours to minimize the aspiration risk. And then, lastly, we have to check for any allergies, especially to sedative or anesthetic sprays. And then, for the equipment preparation, we will have to make sure that all the equipment is properly set and properly sanitized. And then for the TOE machine, we have to make sure that it is turned on and the probe are tested for the functionality. And then we also have to ensure that the resuscitation equipment, including a suction, a defib, and airway respiratory management tools, are available at the bedside. This is to make sure that if during the procedure, if there is any complications, we can immediately provide the first aid to the patient. And then we also have to insert an IV cannula for sedation or fluid if needed, and also make sure to ready or to prepare the oxygen delivery equipment, either nasal cannula or mask. And then finally, we have to attach the monitoring device such as ECG, blood pressure cuff, and pulse oximeter. This is to ensure to this is to ensure and to monitor the patient's vital throughout the whole TOE being done. Okay, so next will be the procedure done during the procedure, which is we have to administer the conscious sedation for the patient, as TOE is generally done or performed under conscious sedation. And then the we also use throat anesthetized with topical spray or gel. This is to suppress the gag reflex from the patient. And also, once the sedation is administered, it is crucial to continuously monitor the patient's heart rate, which is the vital sign, and also monitor the oxygen saturation throughout the procedure. And then the patient should also be positioned in their left lateral position, which is laying on their left side, to facilitate the probe insertion into the throat and to ensure the patient is comfortable. And then we usually put a bite block into the patient's mouth. This is to protect the patient's teeth and also to ensure smooth, delicate probe insertion. And then this is important for us to take note on. When inserting the probe, we have to make sure that the probe is inserted gently and smoothly, and we can never force the probe insertion. So if resistance is encountered, we have to stop and reassess the patient's condition, as forcing the probe can cause serious injury or bleeding to the esophagus. And then once the probe is in position, we will begin with the systematic imaging. So the imaging we capture would be the mid-esophageal views, including the four-chamber, two-chamber, and parasternal long axis view. And then we will move to the transgastric view for cross-sectional imaging of the ventricles. And then finally, we have to monitor the upper esophageal view. This is to allow the assessment of aortic arch. And then throughout this whole procedure, the basic echo Doppler will be used or applied to adjust and optimize the image quality. Last but not least is the post-procedure method. So basically, for the post-procedure, we will have to carefully withdraw the probe carefully and slowly to minimize the patient's trauma. And also, we have to inspect the probe if there is any physical damage or any bleeding, such as cracks or blood stain that would indicate the internal injury of the patient. And then we will have to continuously monitor the patients as they recover from sedation and ensure that they still remain fasting until their gag reflex has returned fully back to prevent aspiration. And then the post procedure care focuses on monitoring for complications such as sore throat, bleeding, arrhythmias, or very serious esophageal injury. If sedation was given, we will have to advise the patient not to drive or not to operate any machinery for at least 24 hours once they have awake from the sedation. And then we also have to make sure that they understand who to contact if they develop any chest pain or difficulty swallowing or bleeding. And then lastly, we have to make sure that the proper documentation is done, and we need to save all the captured image and archive all the captured image for future references in case the patient has undergone a similar symptom in the future. And then if any significant findings are obvious or are seen, we have to provide a preliminary report to the treating team, and we have to also prepare a detailed and formal report will follow after the cardiologist full review. So basically, the documentation is where we prepare the report. At the same time, we will have to consult with other healthcare professionals in order to provide the proper and accurate report for the patient's condition. Thank you.
I will explain about the application to clinical case. So why TEE was chosen in this case because it provides superior imaging of structure like the coronary sinus, atria, and vena cava compared to transthoracic echocardiography TTE. In minimally invasive cardiac surgery MICS, the limited surgical exposure makes direct visualization of vascular anomalies like PLSVC impossible. So TEE becomes critical for intraoperative diagnosis. TEE can quickly and accurately detect abnormal venous anatomy like persistent left superior vena cava in real time during surgery. It allows guided cannulation under direct vision, which was crucial once the PLSVC was found to ensure adequate venous drainage for cardiopulmonary bypass. TEE is highly relevant to this case because it enabled the unexpected diagnosis of a PLSVC that was missed preoperatively. It guided changes in surgical management like placing an extravenous cannula to ensure proper venous drainage during cardiopulmonary bypass. In MICS, where direct visualization is limited, TEE was essential for identifying hidden anatomical anomalies. TEE also helped prevent serious intraoperative complications by allowing timely detection and adaptation. The expected outcome in this case was uh, su- successful identification of all cardiac and vascular anatomy before critical surgical steps, safe and complete venous drainage during cardiopulmonary bypass by adjusting cannulation techniques, effective minimally invasive surgery without major complication, and the last one is stable post-operative recovery with the patient successfully extubated on post-operative day 1 and no immediate major issue.
I'll be explaining on image analysis. So the first one would be 2D TEE lower esophageal four-chamber view. So as we can see, in our patient, the coronary sinus was dilated around approximately around 3 centimeter, where the normal value for coronary sinus should be less than 1 centimeter. And the next one would be 2D TEE mid-esophageal view, where we can see the enlarge of the coronary sinus as it stands laterally to join the PLSVC. And so it may be seen along the lateral aspect of the LA, left atrium, and also the left atrial appendage, which is LAA. As you can see, the LAA was shown in the echo image, but the arrow is showing the LAA. Alright, moving on to the 2D mid-esophageal four-chamber TEE imaging, where the injection of agitated saline through the left upper extremity peripheral intravenous catheter demonstrated the bubbles immediately appearing in the PLSVC. So it suggests for a rare PLSVC because it appear on the LA first, where it should be appear on the right atrium. No, from the coronary sinus and then the right atrium. Alright, moving on to 2DT in mid-esophageal four-chamber serial views, where it demonstrates the early appearance of saline bubbles that arise via the coronary sinus to the RA, which is the echo image A, and then the bubbles are seen to progressively opacify the RV mildly, which is the echo image B, and then moderately in the echo image C, and densely in the echo image D, following the injection of acetylcholine through a left upper extremity peripheral intravenous catheter. Alright, so next, the presence of a right-sided SVC was also confirmed on upper esophageal and mid-esophageal bicaval images, where it demonstrates a right SVC joining DRA along the right side of the image and a dilated coronary sinus to the left, which is the blue arrow in the echo image. Alright, the last echo image would be 2D TEE mid-esophageal simultaneous orthogonal biplane imaging views, where it demonstrates the PLSVC in the echo image where it marked star is so on the left side is the short axis and on the right side is the long axis view, where it displays a venous cannula, the arrow on the echo image, that was inserted through the left subclavian vein is also noted in the PLSVC.
Assalamualaikum. My name is Nonali Farzana and will be presenting about the findings from the result that were presented by Akila. So there are many points of the findings that have been found in this research, which is firstly is PLSVC is a common but often undiagnosed venous anomaly. Although it is a rare overall, PLSVC is the most frequent thoracic venous anomaly and was discovered intraoperatively in this case, which highlighting that it is easily be missed on outline of preoperative imaging transthoracic echocardiography, which is known as TE. Next point is transesophageal echocardiography. TE was crucial for diagnosis. Why it is crucial? Because intraoperative TE detected a significantly dilated coronary sinus, which is 3.0 centimeter, and identified the PLSVC by observing bubble contrast entering the coronary sinus, which burst during an agitated saline injection via a left arm IV. Furthermore, the findings that we have found is the presence of PLSVC complicated venous drainage management during MICS. Since standard venous cannulation through the femoral will not adequately drain the left SVC system, an additional cannula was placed into the left subclavian vein to ensure proper venous return and effective cardiopulmonary bypass (CPB). More than that, failure to recognize PLSVC can lead to multiple complications. Here is the multiple complications that we can found if failure of PLSVC. Firstly, is placing central venous catheters, pulmonary artery catheters, pacemaker leads, and risk during CPB, such as poor venous drainage, flooding of the surgical field, ineffective cardioplegia, and incomplete cardiac decompression. We will go to the last slide. There are 3 points into the findings. Other than that, the LSVC can severely impact myocardial protection strategies, since standard venous cannulation through the femoral will not adequately drain the left SVC system, and additionally, an additional cannula were placed in the left subclavian vein to ensure proper venous return and effective cardiopulmonary bypass. Furthermore, we have timely intraoperative identification of PLSVC changes surgical strategy. So early diagnosis during surgery allowed adjustment that prevented potentially dangerous complication, which demonstrating the essential role of skilled echocardiography during MICS. Lastly, is minimally invasive surgery increases diagnostic challenges. Unlike open sternotomy, MICS does not allow for direct visual detection of abnormal veins, making reliance on imaging tools like PE absolutely vital. So that's all from me. Thank you.
Good afternoon, my name is Yashni and I'll be explaining about the conclusion. So in this case, as we showed, they have showed that a persistent left superior vena cava, which is actually unexpectedly found during the minimal invasive cardiac surgeries. So they used intraoperative transesophageal echocardiography in order to discover this. And this discovery during the surgery mainly highlights on the critical role of TEE in detecting the hidden cardiac abnormalities that might not be picked up preoperatively, especially when imaging from outside of the institution, which is incomplete. So this early diagnosis allows the surgical teams to modify their bypass strategies by replacing an additional venous canal, preventing the complication like poor venous return or operative field flooding. So one of the benefit of early detection through TEE is actually by optimizing the venous drainage and also cardiac pulmonary bypass management. So, moreover, it also helps to reducing the intraoperative risk such as arrhythmias and also cardiac arrest. By supporting better outcomes in MICS, when direct anatomical visualize is very limited. So in this case, reinforcement that TEE is not just a diagnosis, is not diagnostic, but it is very essential in order to perform a safe surgical planning in the minimal invasive cardiac procedures. So that's all from us. Thank you.